So if these are too simple, I apologize, and if they're too hard, I apologize. And thank you so much, SRU, for having me. Thank you for staying till the end of the day. Appreciate it. And um, so when I look at a case, I go through a pattern, a similar protocol, which is to look at the quality, is everything on there? I look at the waveform shapes. I look for symmetry between the two sides, recognizing that the vertebral artery may be asymmetrical. And then I look at the numbers. So the numbers are really a part of it. But because Leslie spoke earlier on all the other stuff that didn't involve numbers, we're going to be a little bit number-centric for some of these cases, and for others ones we won't. When I look at a stenosis, I require my sonographers to record 3 distinct parts of the stenosis. Most of you are interested in what's happening inside the stenosis with the highest velocity jet, and that's okay, but that velocity has to be with respect to something, so we want to get a waveform before the stenosis. In the carotid, typically, that's in the common carotid artery just before the bifurcation, and where the common carotid artery walls are parallel before the bulb forms. And then we look beyond that over several centimeters to look for turbulence, because excessive turbulence is one of the things that we look for to tell us that there's pressure reduction. Turbulence is one of the things that cause stenosis, indicates that stenosis is pressure reducing. So here's a waveform: grayscale, color, and spectral Doppler. The other thing is we have these 3 modalities. We want to make sure that they're concordant with one another, and anytime you have discordance between them, you have to explain what that's about. And so you may need to scan more, you may need to think harder, or you may need to give up. Those are your options, okay? If you're lucky enough, when you look beyond, you'll see some evidence of turbulence, and you've seen some examples during the course of the conference so far with to and fro simultaneous flow, simultaneous forward and reverse flow, which is the material twirling around. You can see some linear, some lines sometimes on the waveform, probably related to vortex shedding. And then if you're in carotids, we don't usually do this, but in other vessels like renal arteries, we can look far distal to look for very low pressure downstream. Again, that usually is evidenced by the tortus parvis waveform, which has either a slow time to upstroke, the tortus part, or too much diastolic flow because the pressure difference between systole and diastole are similar. So you get lots of diastolic flow with a slow upstroke. So this is your tortus parvis waveform. And I'm trying to cure my dyslexia. For years I say parvis tortus because that's what it sounds like to me, but I'm trying to turn it around. And John reminds me that this looks like a TP, so remember tortus parvis, so there you go. Okay, so there are a bunch of criteria that we use for degrees of stenosis, and I just want to kind of pitch to you 2 things. One is, I am a strong believer in high-grade stenosis criteria should use end diastole. And what happens in a stenosis is that you have narrowing and you have a pressure gradient. And that pressure gradient is most profound during systole, but when you get worse stenoses, you have a pressure gradient during diastole and systole. And as Bernoulli taught us, when you have a pressure gradient, you have high velocity. So the presence of high velocity during diastole is related to more severe stenosis. So it's a more specific sign for high-grade stenosis, typically in the 70 to 99 range, which is the more severe range by NASAT. Okay, now, usually try to talk to you and give you one thing to think about for next year, and the thing I want you to think about has to do with these high-velocity waveforms. And here we see lots of systole and lots of diastole. Okay, is this related to resistance? So we've always seen lots of diastolic flow. Well, the diastolic flow here is 130 centimeters per second, very high diastolic flow. Does it make sense to call this a low resistance waveform? And I'm not going to answer it. And I know Leslie's going to ask me later, but I'm not answering it. Okay. So as a rule, some of us use internal criteria, some of us use other criteria. This is from Ed Grant, Most people use the primary parameter of peak systolic velocity. Others use combinations with ratios and with end diastole. These are the numbers from the SRU Consensus Conference. And for the point of today, we're going to use these numbers, even though I might not use exactly these numbers in my own lab. Okay? And so I've been asked to talk about difficult cases, so let's go and show some difficult cases. And here's a list of what makes things difficult, and you're going to see examples of all these as we go through. So I'm not going to try to tell you. So let's start with the case of the late stenosis, okay? So here's a patient. You can see the common carotid artery. Here's the carotid bulb, and the proximal internal carotid artery looks pretty good. And then as we get distally, it looks a little funky here. Here's a blow up of this vessel. Again, this is nowhere near the proximal internal carotid artery. And you can see these echogenic lines that are sitting inside of it. Those are associated with higher velocity. The vessel is straight, but there's aliasing here, which means that the velocity has gone up through that region. Here in the common carotid artery, the velocity is 69. In the proximal internal carotid artery, where there's no narrowing, it's 59. And here in the region of interest, it's 223. And as we go beyond it, as we profile it, it drops off to 125. Okay? So here's the picture that everybody's interested in, 223 centimeters per second in a funny place. Whoop. So any thoughts? Well, this one I'll give you free. The first one I'll give you. So this is not in the right place. Here's a stenosis in an area that's not supposed to be stenosis. Atherosclerosis typically involves the first few centimeters. So this is a case of fibromuscular dysplasia, and pretty straightforward, nice example of it, okay? Couple of pitfalls, though. The distal internal carotid artery, as it turns away, can frequently be a little bit higher. So normally you get in a normal ICA something like 80, 60, 80. But when you get to the distal, it may go up to 100, 120, and it may even go to 130. Again, not uncommon. Again, they're not associated with downstream turbulence from that, and they're not associated with abnormalities. And it's related to the fact that the vessel is diving away from us, it's curving a little bit, and a few things are going on. The criteria that grant the NASID criteria are really only good for the first few centimeters. So the fact that something is higher to 130 doesn't mean you call it a stenosis. But when you see very high velocities with bruits and with the suggestive symptoms, which may be cerebrovascular symptoms, or the patient hears a bruit in their ear, which is very typical of FMD, you should be thinking about FMD. Okay? The thing I want to talk to you about, the thing that's difficult is most of us want to grade FMD, and the current recommendations by the FMD committee is you don't. You just say FMD is present. From a point of view of description, it either has one focal area of FMD or there can be a multiple area of FMD. And so their description is focal or multifocal. In this case, there are multiple webs, and therefore it's multifocal FMD. And also remember that FMD frequently involves multiple circulations. So when you find FMD or suspect FMD, you want to confirm it. And we typically do that with a kind of total body CTA. We go from basically from the head all the way down to the femorals. Okay? Now, next case, the case of the meandering vessel. This is a patient who has sigmoid ICAs. The proximal ICAs are not in either of these pictures. This is kind of the mid to distal ICAs. Okay, so that's the first piece of information. So everybody recognize that? I'm going to need some feedback from you guys here. It's almost time, and you're probably all drooling at this point, and falling asleep. But I kind of need you awake to give me some positive feedback here. Everybody sees the sigmoid shapes? Okay, did everybody notice the age of the patient? Does anybody have a diagnosis for me? Pardon? Ehlers-Danlos. Well, it's close. There's something wrong with these vessels, but it is FMD. So FMD is associated with the sigmoid shape, particularly in young patients. Now, FMD is being seen in older and older people, but when you get people who are not in the atherosclerotic range, and why is this important? This is not a narrowing, this is not a stenotic lesion. These are just sigmoid shapes, but the point of FMD is that you're associated also with aneurysms and other areas, such as renal FMD. So you want to treat this patient with a diagnostic CT scan to exclude intracranial aneurysms as well as other sites of FMD. Curves will, the velocity will accelerate around curves, so you have to be careful. Be careful about cholangiostenosis. Frequently, it's just the fact that there's acceleration. And elongation is not, is very, very common in older patients. So when I see this in the elderly population, which I am getting to moment by moment, then I would probably not worry about FMD and just recognize that it's just the vessels elongating as time goes on. Okay. So part of what I decided to talk to you about were difficult cases, but part of what makes ultrasound difficult is that you rely in total or in part on the sonographer and the vascular techs giving you good information. So we're going to show some cases today where the sonographer is new, the sonographer is old, and maybe a few where the sonographer is in between. All right, and so most of you who have sonographers of a certain age, they have told you that, you know, they've been doing this for the last 40 years, and who are you to tell them that you're doing it wrong? Or, you know, they just have their way of doing it. I'm sure that Mary Frates is here, right? That doesn't happen at the Brigham, but it happens at places like my place. Okay, so this is so the other thing is that it's what's happening to me is we're getting more and more hospitals, right? So we're inheriting all these hospitals. So we had a cadre of people we trained, and now I get, who knows? It's really funny, one of the hospitals that associated with us have 4 sonographers that we refuse to hire. So, you know, be careful what you wish for, it may come back to haunt you. Okay, so these mergers are not always fun, right? Okay, so hopefully you were looking at this. This is the right side. The common carotid is here with this waveform. And here are the films that we were given. Here's the external carotid artery here with an angle corrector here, and the waveform looks like that. And here's the external again with another waveform looks like that. And a couple of pictures of the ICA proximally and distally. That's what's labeled internal carotid artery. And the waveforms look like this. Any problems here with anybody? Anybody have any problem? Pardon? The internals look like the external. Yeah, the big vessel kind of looks like a external carotid, and the little vessel looks like, I'm sorry, is labeled external. And they're switched. I thought. So I called her up, and she goes, pfft. And then I said, would you? So then I had to beg, you know, it's because you only think that you're in charge of anything. And so, so here's what's labeled internal and external, and as Cliff pointed out, there's too little diastolic flow on the image on the left, and too much diastolic flow on the image on the right. Okay, so they're bigger. Okay, so technically inadequate. Do it again. So here are the new pictures, and I got a phone call saying, "Wow, Dr. Needleman, you were right." Cliff, you were right. She decided that this was the internal carotid artery, and now she actually found a branch coming off here. And if you look for it, if you train your sonographers to look for branches on the external, they will find it, okay? So here we found it, and she redid this is the new ICA, which looks more like an ICA, and here's the new ECA, which looks more like the ECA, and life was good. Anybody notice anything else that was a problem? Bad angle correction. This is a very smart group. Okay. So, pardon me? Yes. So I then said, you know, I mentioned it when we talked about the first set of images, but that was a little bit too much for her to handle. So she was able to get the IC-EC part. So, you know, we have to save that conversation about angles a little bit, right? So let's have a word about angles as we do this, right? Most of us, not everybody, but I align the angle parallel to the walls because you can always see the walls. Some people align the angle cursor with respect to the color, and I'm not going to get into that battle today, but we do it this way, and we try to keep an angle which is appropriate. As you start getting too high angles, you start introducing error. So we want to do below 60, and we try to scan everybody's carotid to 60 to be consistent. But the recommendations are to keep below 60 and never use a number if it's above 70. But what this sonographer has been doing her whole career is that she's been setting the machine for 60 degrees, or in 55 in this particular case. And so she's scanning at 60 degrees, irrespective of where the angle is. And, and if you think this isn't going to happen to you, it's going to happen to you, okay? It happened to me. So now you have to kind of explain this. And I had one other sonographer, a case I didn't show you today, who swore, she goes, I've been an RVT for 14 years, and no one has ever told me that I'm using the wrong angle. And I said, I absolutely believe that nobody's ever told you that. Okay, the case of the contralateral carotid, or also known as the case of the contralateral conundrum. Okay, so I'm going to do the left side first. Usually we just scan right side first and left side second because it's the way we do it, but this I'm going to show you out of order. So here's a carotid. It's got a big plaque that's got calcification in it. There's some narrowing in it. There's some aliasing in it. There's a lot of aliasing. The velocity here is 92. Then in this vessel is 343 with an end diastolic velocity of 149. Really an easy diagnosis, I think, for everybody. Here's the downstream turbulence. It's got all the criteria, and then as it goes down, the velocity heads back down to 118. So it's got all the goods we need for calling this a 70 to 99% stenosis, right? Anybody have a problem with that? Okay, the problem for me is the other side. Here's the common carotid artery and the proximal internal carotid artery. Here's the color. There's a little bit of vortex shedding over here, but I want to just point out what the column of color looks like. Here's waveform 90.7, 200, 214. So we're looking around for the highest velocity. As we go downstream, 159. And then as we go further downstream, 100. Okay? So we have a velocity change. Everybody with me? Okay, so the big question is, what do we do now? We had a high-grade stenosis on one side, and we have this on the other side. All right? So what do people want to call the right side? How many people want to call it normal? How many people want to call it above 70%? How many people want to call it 50 to 69%? How many people want to call it less than 50%? Really? Jeepers, this is a really smart group. Okay, so what everybody knows here is that when you have a high-grade stenosis or an occlusion on one side, the brain gets its flow. It's auto-regulated. It's got to get its flow one way or the other. So if you have a tube and you get more flow through it, the velocity has to be faster through that tube, okay? And so contralateral, more flow in the same size vessel produces increased velocity. And so what do? What are the ultrasound rules? Well, I will tell you that I've been following the ultrasound literature on this forever, waiting for an answer, and there is no answer so far. There are people who said you subtract 20 centimeters per second from the number. Some people say you subtract 30 centimeters. Some people say you abandon it completely. You just say there's something there. Other people say use a ratio. I don't want to say who may do what. I just look at the grayscale, look at the color, and I generally move it down by one full grade. So this had a ratio of slightly more than 2 to 1, and my grade, which would put it as above 50%, but now I'm going to downgrade it. So, and the grayscale and the color did not look bad, so I'm going to call it less than 50%. Okay? Anybody have a problem with that? Anybody not have a problem with that? Okay, excellent. Good. Somebody didn't have a problem with that. Okay, and here's another one at 196 that had an angiogram. Okay. The case of the confused carotid. By the way, I am told my PDF did not arrive, and so they say it's going to be put on, so look for it tomorrow. Okay, so here is a waveform on the lower left of the common carotid artery, and here is something my sonographer, Ken, is telling me that he thinks is the ICA. I will tell you that there was an ECA that had a very typical waveform in it, And so this is what he got. And these are the color pictures of that area that he was getting this waveform from. Okay? Do I have a brave soul in the audience who wants to tell me what they think? Do I have a stupid soul in the audience who's willing to tell me what they think? Man, what? Dissection. Okay. Well, that's a. So this is, it looks to me, thank you, was that Mindy, I believe? So there's a lot of stuff in here. Dissections as a rule are a hemorrhage in the wall. This kind of looks a little more irregular. And this patient is 78 years old. So dissections are a good thought. It's one of the things that can give you a highly pulsatile Doppler waveform. I did want to point out the velocity here. That was some high number, 250 or even more. Other higher. Okay. So does anybody want to commit to A, B, C, D, E, F? All right, let's do it this way. Any A's? Any B's? C, D, E, F. Oh, I got an E. F, G. G, technically inadequate. It was, well, it was the best we can do. So I got one vote for one E. So I don't know who you are, but you're a genius. You're absolutely right. This is a very strange waveform. And it has very high velocity. What is going on here? Well, this is this famous Spencer-Reid diagram. And what happens is as you go up, your velocity goes up, and there's a point at which your velocity goes down. But in this area right here, it's a very strange place. There are all sorts of weird things going on. And what's happening is there's so little lumen here that sometimes you get high velocity, sometimes you get normal velocity, and sometimes you get low velocity. So you get these weird things that are happening. But what's happening is during systole, you're pressurizing enough to get the pressure gradient. But basically, when you start dropping your pressure, it basically is so small it closes. And basically, you get what looks like reversal. Basically, the stuff gets sucked down. So you get this weird flow, which is present or released. That's how I interpret it. The patient did have an angiogram. And the other thing that was important to recognize was this was a very long lesion. And the numbers that we're talking about, again, the Grant numbers or any of the numbers, are based on a couple of things, which are short stenoses. Once you get to long stenoses, the normal rules do not apply. So this is either to and fro because of the resistance related to this very long stenosis or related to the degree of stenosis or both. Okay? And by the way, on color Doppler and power Doppler, it looks like a very severe looking stenosis. John, did you vote?
Yes.
Which did you vote for?
E.
Of course you did.
It was obvious.
I would expect no other answer. Okay. This is the case of the slow sonographer. No, I'm sorry. Did I say that out loud? I apologize.
You did.
The slow carotid. Okay, so there's a power Doppler image, and there's a spectral Doppler image with a velocity, and the velocity here is about 20 centimeters per second. That's what makes it a slow sonographer. Okay? So same thing. Let's see if I can get two people to vote for this one. What do you think, John? You think I can mobilize double my possibilities here? Easy, okay. A, anybody, A. B, one B. C, D, E. I got 1, 2, 3, 4. I got a lot of E's. Oh, and little Johnny. F.
Little.
And G, anybody G? Okay. This was near occlusion. And this is just like we were talking about before. We were up here for that first weird case. This is now a little bit further down the road where you have, again, a very long stenosis where the lumen is so tight you can't even get a fast velocity through it. It just is kind of squeezing through it as you get through this range. So again, it's either related to small size, and the small size can be due to a couple of things, right? One thing it can be is you don't have enough pressure in that artery to actually make the vessel expand, or so it's just shrunk down because it's a very low, small thing. If you saw the musculoskeletal section, it was very much what happens to nerves, right? The nerves swell up, and then distally they get all shrunken. So the vessel is small, and our angiographers call that adaptive narrowing. So it could be that it's actually a shorter stenosis, but it's got no pressure, or it can be that it's a long stenosis. Those are your two options. It doesn't matter. They're near occlusions, and they are associated with kind of the end of the line for these patients. Okay.
Crunchy.
This is an important case because it's something that we face every day. I was at a session, of a vascular meeting, and a guy presented a paper from a very famous institution in Boston, not the Brigham and Women's Hospital, where he said that carotids were not very accurate in the presence of calcifications. And so he said, worthless, okay? And calcifications do represent a problem because you can't see underneath the calcifications, okay? And I totally agree with that. But let's see what we got. We have the proximal internal carotid artery with a shadow. Everybody see the shadow? I know it's late in the day. Everybody's good here? Okay, good. Common carotid artery, 109, 79 right before the calcification. In the shadow, nothing. Beyond the shadow, 79, but with a whole bunch of turbulence, right? Okay, so what do you want to do? Measure the length of the shadow. You've obviously heard this lecture from Dr. Pollack, where he claims that the length of the shadow is related to the accuracy of the ultrasound. And I will tell you that I heard that lecture, and I've been looking at that myself, and much as I love Dr. Pollack, I have not been able to confirm his results. So, good thought, but not today. But it's not a bad idea to. So what's the problem? You want to see what the hell's going on underneath it, right? Anybody not think this is a technically inadequate study? How many people would read it as less than 50 because it was 78 on both sides? Nobody, because this is a very smart group. And they all said there's a lot of turbulence there, we're really nervous. So some of us might say technically inadequate study because there's turbulence and I don't know what to do with it, right?
And there was one other thing.
There's one other thing.
There was reversal in the common.
There was reversal in the there was a little reversal right here. Good point. So you're thinking there's a lot more action going on.
Yeah.
Okay. Well, so what do you do? So that's an interesting question, right? So I have 28 minutes, and I don't know how many cases I have, but let's talk about this for a few minutes. Right, I mentioned this to the sonographer. I said, there's a big calcification there. And they go, yeah. I said, you didn't mention that there was a big calcification on the worksheet. They go, I know. And I said, kind of helpful to do that. And one of the things that you have to realize when working with sonographers is that when they don't know something, there's two options, right? One is to hide it, and the other is to reveal it, right? And this is the difference between what we call guilt and shame, right? Guilt makes you kind of confess, and shame makes you hide. And the point is that you need an environment where question marks, anything uncertain, gets opened up. This is their opportunity to talk to you because they have a problem. So I said, next time put it on the preliminary and let's see what we can do. So what I suggested is we try scanning a little bit more, okay? And so I said, well, you know, most calcifications and most plaque is not symmetrical. So if you find a different angle, you might be able to find the lumen. And sure enough, we went to a different place and we found the lumen going through. And now we can put our Doppler through it. There's one other thing that I don't show here, and in fact, I routinely also tell my technologists to angle the steering box downward instead of upward, because they're always thinking about putting the box up towards where they're going. But you want to get underneath this plaque. So the other way to get under the plaque is by angling downward, because the shadow is going to cast itself down towards the feet, and you get a little bit more inside of the plaque. So that's another trick that I tell them to do. So we did this, and they actually found a peak systolic velocity of 159. There is not a lot of diastolic flow here. This is a patient who had other cardiac issues, John. So that was a good pickup, but I'll show this another year for heart problems. But the ratio turned out to be 2, and we confidently made this a diagnosis of 50 to 69%. Okay. Anybody know what movie this is from? This is from High Anxiety by Mel Brooks. Okay?
Yeah.
Okay. So this is the right vertebral artery. Okay? I have showed this case to John and a panel of 5 experts, and nobody picked it up.
You're not giving the scale. You can't tell the direction of flow.
The direction of, actually, it's funny you should say that because here it is. It's flowing in the proper direction, John. It's not inverted. There's your waveform. And if the number is 35, it's flowing in the proper direction. Okay, so what do people think? Pardon? Am I sure it's the vertebral? Well, I know the answer. Are you sure it's the vertebral? Okay, well, the vertebral is typically found someplace between the lateral masses, and I don't see lateral masses on this picture, so this may not be the vertebral. Remember, the vertebral doesn't necessarily have to have the external carotid branches are lying up there, and so it looks like an external one. Okay, so we told them, no good, keep on looking. So again, I would have been happy with that being a vertebral, except that it was in the wrong place. So you got to look at the pictures, and you got to see where it comes from. And in fact, when we scanned in the proper place, we did get a to and fro sign. The vertebral artery was there. So again,
What vessel is that?
that is just probably, I don't know, it's the thyrocervical trunk, John. How's that?
Yeah, sure.
Okay. Thank you very much.